All right, Millen, you want to give a brief opening?
Not much. I guess I'll hand this over to you, Herman and Arpita, to introduce the speaker. We are very grateful to have Professor Munmun Choudhury here today, but I'll hand this over to you to do the introductions and start off the proceedings.
All right. Well, it's an honor for me to introduce Dr. Munmun Choudhury. She is an associate professor of interactive computing at Georgia Tech. Her research is best known for laying the foundation of computational techniques to responsibly and ethically employ social media in understanding and improving our mental health. And to do this work, she adopts a highly interdisciplinary approach combining social computing, machine learning, and natural language analysis with insights and theories from the social, behavioral, and clinical sciences. Earlier this year, Dr. Choudhury has been recognized with the 2021 ACMW Rising Star Award. She also received Complex Systems Society Junior Scientific Award in 2019, as well as 13 Best Paper and honorable mentions from the ACM and AAAI. She has been extensively covered in the media like the New York Times, the NPR, and the BBC. In 2020, Dr. Choudhury served as the general chair of the 14th AAAI International Conference in Web and Social Media, which is the leading conference in interdisciplinary studies of social media. Earlier, Dr. Choudhury was a faculty associate with the Berkman Klein Center for Internet and Society here at Harvard. And she was also a postdoc at Microsoft Research and obtained her PhD in computer science from Arizona State University. And with that, I invite everyone to give warm welcome to Dr. Moonmoon Choudhury to present her talk on bridging machine learning and collaborative action research, a tale of engaging with three stakeholders in digital mental health.
Thank you so much, Harman. It is my pleasure to be here today and to have an opportunity to talk with you all. I just wish that this could have been in person, but we will make do with what we can at the moment. So my talk today, it's going to review some of the work that we have been doing at the intersection of social media and mental health over the past few years. And hopefully it would make you think a little bit how lenses that we can adopt from the social science field can provide hopefully richer, deeper, and more useful outcomes when it comes to using AI for societal good and deriving benefits from that while minimizing harms. So, it goes without saying, we all know that with the adoption of different digital tools, such as online platforms, social media, and whatnot, we now have, very rich digital data traces that are left behind by individuals while they're using these platforms. And over the past decade and a half, a new field has emerged called the computational social science field. And it has made a lot of significant strides in trying to improve our understanding of a variety of different social phenomena. And, these data have now provided, for instance, newer ways for us to measure our interactions, our moods, our emotions, political ideologies, collective action. And computational social scientists have also made a lot of significant contributions when it comes to improving our understanding of political events, crisis events, our health and well-being, and of course, our civic engagement as well. So in the initial part of this talk today, I'll take the opportunity to share with you some of the highlights of our work that we have been conducting with our collaborators, my students, over the past few years in the computational use of social media data for mental health purposes, and doing that in an ethical and responsible manner. And then I'm going to spend large parts of my talk today talking about sort of the next frontier of this research and hopefully how synergistic and critically leaning approaches, when they're combined with when they combine AI and computer science and social science insights, how that can help us realize sort of some of the potential that these computational uses of data can give us in the context of mental health. Okay, so here is a very quick overview of some of the early findings of our research. So I'm going to adopt an ecological approach here to tell you this very short story. So we'll go from the individual, we'll talk about communities, and then larger populations. So starting with the individual, this early work from 2013, we wanted to explore to what extent social media can be a useful lens for us to understand the changes that people experience around major life events. So here we looked at childbirth as a life event, which is not just a really important milestone in people's lives, but it is also something that people do talk about on social media platforms. So we looked at new moms who had announced a childbirth on Twitter, and we looked at their Twitter data several months preceding the reported childbirth and several months succeeding that. And what we found in this work is that for about a 15 to 20% of the sample of new moms that we explored, we noticed changes that were indicative of significant behavioral and emotional changes that were connected to postpartum depression. And in fact, what we found is that by extracting various language and social interaction signals from Twitter data of these new moms, we could train forecasting models that would allow us to identify when and which individuals are likely to be at a greater risk of postpartum depression going forward into the future. I'm going to talk about implications together at the end, but let us talk about communities now. So what is it that social media can tell us about the well-being of communities? So in this work, we looked at college campuses as situated communities, and we were interested in how external shocks, particularly in this case, local crisis events, gun violence incidents that have been quite frequent in US campuses over the past few years, how those incidents impact the well-being of the communities. So we looked at 12 schools over a span of 5 years, which had 12 incidents of gun violence spread over this period of time. And we looked at what kind of changes in stress and anxiety do these communities experience by analyzing the Reddit postings that are attributed to these campuses. So what we found is that, not surprisingly, over a period of 30 days following these incidents, the stress and anxiety levels went up, which is something you would expect after any crisis event. But what was more revealing and insightful to us is that by looking at a source of data such as from Reddit, we can not only understand how these communities are experiencing this crisis and the mental health impacts of the crisis, but also it helps us identify potentially the stressors and how these communities engage with each other at the time of a crisis. So we found that in this aftermath of these crisis events, we saw a decline in stressors that were attributed to typical college life, whether it's classes or exams or midterms or homeworks and whatnot. And we saw an increase in people's concerns for others. We saw an increase in feelings of solidarity and feelings of civic engagement. And that persisted for a while after these incidents of gun violence. And then moving over to the scale of populations. So in this work, we developed an index we call the Social Media Depression Index. And what we did here is we built classifiers using Twitter data and people's self-reported levels of depression on the Patient Health Questionnaire 9. And we came up with this index that would give us a measure of the degree to which people express depression at different points in time in different parts of the country. So if you look at the maps, on the left, we have a map of the actual prevalence of depression that is was given by the Behavioral Risk Factor Surveillance Survey, which is a survey that is conducted by the CDC every few years to gather self-reported data on prevalence of depression and a number of other health outcomes as well. And on the right, we have a similar map, but here the color coding is based on the index that we develop using social media data. So if you just eyeball, you would notice that there is a significant correspondence in what we get from social media and what the actual reality is based on the BRFSS survey. Not just that, with this index, we were able to also glean meaningful insights when it comes to understanding temporal changes and experiences of depression, or understanding how different sociodemographic groups experience it, or how it changes across which part of the country you're looking at. So for instance, we found that expressions of depression are higher later in the night and earlier in the morning than during the day. They're also greater when you look at winter and early spring compared to during the summer. And that cuts across whichever part of the country you're looking at. All right. So this was a very sort of high level and quick recap, but now that you kind of understand where the potential lies, you might be wondering, what is the next step in this line of work? Are we ready for any kind of real world deployment of these models, maybe in the form of interventions or other mechanisms? And if we are interested in doing that, what would be the best way to do that? So let me tell you where these potentials lie. So the first potential that came to us after we did this work was to think about tools that would use these algorithmic insights, these insights from AI and machine learning algorithms to connect people with who are in need and in distress with timely and proactive help. And these could be in the form of connecting with other members of the community, connecting with the health systems, connecting them with crisis resources, and so on. And how can we do that in a technologically mediated fashion so that these approaches are scalable across different sociodemographic groups. And then there's also the potential for, let's say, community organizers and stakeholders, public health organizations who can hopefully use some of these algorithmic insights to influence their decision-making, to influence campaigns that they conduct to raise awareness, fight the stigma around mental illness, and influence policy and budgetary decisions around mental health. But given all these potential, the question is, what is really preventing us from pursuing any of this? So I would note 3 issues that we need to pay attention to and address before we can realize the potential of these data and these algorithmic insights. First of all, the question that comes to our mind is, how should these algorithms, which are inferring people's mental health states, negotiate the needs, the demands, and the expectations of people with lived experiences in a way that wouldn't take away their agency, but would empower them so that they can navigate this lived experience in a better fashion. Then there are questions about power asymmetries, right? Power asymmetries already exist between patients, caregivers, clinicians, and so forth. So how can these algorithmic insights be part of those institutions, existing institutions of mental health treatment and care, in a way that doesn't exacerbate these power asymmetries, but in fact, hopefully help us overcome these power asymmetries so that the people with lived experiences and patients can be very much an equal player in their collaborative treatment, rather than having their voice often overridden with clinicians, insurance companies, and whatnot. Then there are the questions of how do we prevent bad actors, right? I mean, and that question comes whenever we think about any algorithm which has the potential for social good. We also have to think about its potential for societal bad. And sometimes that comes from bad actors who might abuse these algorithms, or sometimes even from well-meaning stakeholders who might be deploying them in a way without overseeing or having a blind sight into the harms, and how do we avoid that? And then there are broader questions of ethics around this kind of work, right? So the work that I just discussed uses public data, but obviously just because something is public doesn't mean that it can be used for any purpose. So there are these questions of acceptability and consent and so forth when we are dealing with such sensitive inferences. Then, there are also questions about what kind of provisions should we think about if there were any adverse outcomes to happen, right? When you ask that, when you infer that somebody is at a risk of suicide, what is sort of the moral responsibility of the researchers to protect a vulnerable population or a vulnerable group of people, and how do we do that in a way that minimizes harms while also deriving the benefits from these algorithms. So ultimately, what these questions point to is sort of the need for these three things: agency and power, unintended negative consequences, and ethics, that have to be in some ways part of the research process itself instead of an afterthought. So in the remainder of this talk, I will talk about a theoretical lens that we can adopt to try to overcome some of these gaps and challenges that we have just noted here. So the particular research lens I'm referring to is the action research framework. So for those of you who are social scientists, you know that action research is new. It's been around since the 1940s, attributed to Kurt Lewin, and it's not just a framework. It's actually a philosophy, and it's a methodology of research that is common in qualitative social sciences, and it adopts this iterative, simultaneous process where you take action and you do research, and these two are linked together by critical reflection. And the goal of action research is often transformative change. So the idea is there is a gap. There are things that need to be addressed in a community. How do we do that in an iterative fashion where we are doing the research and also deploying the research to understand its impact on people? So it is in some ways a spiral of steps. That's what the formal definition says. And it has planning, it has action, and then finding out about the result of that action as part of the whole gamut of things. So here's the challenge, though. When we are talking about computational work, we are talking about AI, there isn't any formal guidance about how you would go about using an action research lens in this work, because it's predominantly prevalent in the qualitative social science domain. A lot of ethnographers use that. A lot of people who do field work use that. But when you're dealing with, let's say, already existing data that people have left behind because of technology use, how do we conduct these kind of research in a way that allows us to take that critical approach of action research? So what I'm going to do is I'm going to talk about three case studies in the remainder of the talk to describe how we can use a community-based participatory approach, a collaborative approach that involves diverse stakeholder as a part of the research methodology itself, as a way to get at that action research approach. So moving forward, the first case study is a collaboration between our lab and a health system called Northwell Health. They are a major health system in the state of New York, and they also do cutting-edge research around serious mental illnesses while also providing treatment to individuals with these lived experiences. So our project is called Thrive, and the goal of this project is to think about how these AI and algorithmic insights can be made a part of clinical tools that are powered by the data of patients and people with lived experience of mental illness for two goals. One is to assist the clinicians in their decision making and to augment their abilities to tailor treatment to people as and when they need, and in a proactive and timely fashion. And then the second, to empower the people with the lived experiences themselves. So how can these tools be a way for people to be more self-aware reflect on their behaviors, identify stressors and factors that exacerbate their mental health or improve their mental health, and then how can those kind of tools allow these individuals to become an active voice in their treatment process. So there are several projects within Thrive. I'm going to take an example of one project and go a little bit deeper into what we did here. So this question is around relapse, and we are talking about people with serious mental illnesses. We are talking about patients with a diagnosis of schizophrenia or early psychosis, which is a major mental illness that affects millions of people worldwide. But what is even more alarming and challenging about this condition is that even for people who are under treatment, a lot of them undergo a relapse over a short period of time. And relapse here would mean significant exacerbation of their symptoms to the extent that it would need some kind of a hospitalization for this individual. But here is the challenge. Right now, whether it is for the patient or for the clinician, understanding of relapse, as much as both parties want to identify relapse in a proactive fashion, right now, the understanding can only be gathered retrospectively, which is when the symptoms of this individual has exacerbated enough that they are now back to the health system, and the clinician has to admit this patient to the hospital. And that's when they get to know that, okay, something needs to be corrected about this person's treatment. This is problematic because once a relapse has happened, chances of future relapses get higher, statistically speaking. And also, as there is a decline in symptoms and mental health, it gets difficult to bring back the treatment on track for this individual so that they can continue to function and perform the duties and responsibilities that they have in their lives. So the question here was like, can we actually predict relapse ahead of time and therefore change in some ways status quo in terms of how schizophrenia patients are provided treatment? So as you can imagine, patients are a very important piece in this research. And with an action research framework, it allowed us to engage meaningfully with patients. Because after all, it is the patients whose data is going to power these investigations. And also, it is that population who are going to benefit the most from the models. So we did preliminary work that I'm not sharing the results of, but we got overwhelming feedback from patients at this health system in their willingness to share their Facebook data with the researchers who are part of this project. And the results that I'm going to be discussing are over a sample of little over 100 patients, half of which experienced a relapse related hospitalization, and who gave access to their Facebook data, which was longitudinal and very rich, allowing us to model the change that these individuals experienced over long periods of time. So now let me tell you a little bit about the considerations of our modeling approach in predicting relapse. And these were guided with several iterative discussions with the clinical partners as a part of the action research frameworks. So the key understanding and recognition here is that relapse events are multifactorial. They manifest in all kinds of different ways in different people. In a sense, you can think of them as what is known as clinical heterogeneity. So one person's experience of relapse and the symptoms that describe that will be very different from another person. The other challenge in this modeling, in our modeling approach, was that there are actually no true positives or true negatives in this setup that you could just adopt a supervised machine learning approach, because any individual at any point in time actually has a non-zero likelihood of experiencing a relapse. It's just a matter of time, right? So with these limitations of supervised learning approaches, what could be alternatives? The alternative that we wanted to keep in mind also had to be something that could be clinically useful and meaningful to the clinicians. So how does a clinician currently extend treatment to a person, right? They are not interested in knowing whether an algorithm has so much accuracy or so much area under a rock curve. What they really want to know is, given this patient that I'm currently interacting with, who's sitting in front of me, um, what is the likelihood that this particular person might be at a risk of relapse going forward, let's say a month down the road or 2 or 3 months down the road? So how do we accomplish that from a machine with a machine learning approach? So to do this, we thought of the relapse prediction problem as an anomaly detection problem. So you have somebody's behavior in the form of, let's say, time series signals, longitudinal information about what they're saying or doing on a social media platform like Facebook. And then you identify when those anomalies are likely to occur. So in the context of relapse prediction, those anomalies could be indicative of exacerbated symptoms or other information that the clinician can use to tailor treatment and make arrangements to prevent the relapse from occurring altogether. So essentially, we are looking to identify aberrations in behavior. So what we did is that for every person in our data set, we considered periods of health, which span from 1 to 3 months, and then periods of relapse, which are essentially the anomalies. And these are data spanning a month before a recorded hospitalization. So what did we find? So we built a one-class support vector machine classifier, which is a state-of-the-art anomaly detection approach. And here is what we found. So our method did pretty well in terms of specificity. So here specificity means relapses which were correctly predicted by our algorithm as relapses. We could do that pretty well in 79% of the cases. But what we didn't do so well on is sensitivity, which is the case when our algorithm thinks a certain case of an individual is likely to be a relapse, but in our ground truth data, it is recorded as a healthy period. So there we suffered, our algorithm suffered a lot in their performance. We only could identify, our sensitivity was about 37%. So now action research, right? We want to not just build this algorithm, we want to go back and see where is it working, why is it not working? That is at the core of this approach. So adopting that approach, it allowed us to identify why did the sensitivity look like to be so low in the case of our algorithm. So we did an iterative error analysis. What we did is we referred to another source of data here. These are medical record data. So essentially chart review data, clinical chart review data for each of these patients, which are sort of free-form text that clinicians maintain for their patients that records and summarizes their main insights from different consultations. So again, it is not, sometimes they are rich, sometimes they're recorded, other times they're not. So this is not a consistent source of data. But for 45 of the false negatives in our data set, for about half of them, we did find some data recorded in these chart reviews. And in fact, out of what was shocking to us is that for 90% of these cases, there was something alarming that was noted by the clinician at the time it was documented. So clinicians noted presence of exacerbated psychotic symptoms, other other alarming symptoms of schizophrenia. But at that point in time, these clinicians did not judge the symptoms to be severe enough that would warrant a relapse hospitalization. So because our ground truth data isn't looking at this rich context of the decision making of the clinician, it's only recording whether the person was hospitalized or not. So it looks like in these 18 cases that it is not a case of relapse. But if you were to look back and look at the context, probably they could have been. Who knew? If the symptoms were a little bit different, or if the clinician, if it was a different clinician, it could have been a different outcome altogether. But what is important for us to then recognize is that what our algorithm is picking up from the social media data is indeed valuable. It aligns, it has been able to identify those exacerbations of symptoms in the form of anomalies, which does resonate with what these clinicians also recorded in these chart reviews. All right. So, what were the major takeaways of this work? So, this action research approach allowed us to not just build yet another algorithm. We have plenty of them right now, predicting all sorts of risk scores when it comes to different health outcomes. But it actually allowed us to go deeper. Like, when do these algorithms work? When do they not work? What is the broader context here? And it allowed us to now, think about questioning the status quo about how we think about relapse from a clinician's perspective or from a patient's perspective, and what is it that could be done to prevent these outcomes altogether. So, with a lot of opportunities for better evidence-based clinical decision making. So that was the first case study that I wanted to talk about. Let me now talk to you about the second research effort, the second case study, which is a very different flavor of collaboration, this time with a public health organization, CDC, who are local to us here in Atlanta. So this work is based on now almost 2 years of collaboration with the CDC, and our central goal here was to inform suicide prevention efforts that could use social media in conjunction with other forms of public health signals. So I'm guessing a lot of you know about it. The rates of suicide in the US over the last 20 years have been increasing across all sociodemographic groups. So, in spite of the urgency of this problem, I mean, this has kept organizations like awake several nights in a row. It still does. What is causing these hikes, right? But more importantly, what is challenging to them from a practical perspective is that there is no real-time information right now on suicide fatality trends that they could use to guide their prevention efforts. So, in fact, national statistics on suicide rates, which are given by the National Vital Statistics System, essentially a system that records death certificates that are provided by coroners and medical examiners throughout the country, and the record different causes of death. Here, we are interested in deaths attributed to suicide. This data, very rich and reliable data, but this data is delayed by 1 to 2 years. So in 2021, when CDC is going to the government and asking for their budget on suicide prevention, the most recent data that they have access to is data from 2019. That's a problem because the rates of suicides have increased over the last 2 years, and we don't quite know how much, where, and in which groups. If these rates were stable, then you could use historical data, but because this is not the case, this delay and lack of real-time data is causing serious challenges for organizations like CDCs to make budgetary decisions, deploy interventions, or adapting policies that could improve timely access to care. So it addressed this gap. A couple of years back, folks from the Division of Violence Prevention at CDC reached out to me, and they were interested to see whether online data could be a source of that missing real-time signal that could potentially be used to, identify real-time trends of suicide throughout the country. So what we did is we considered social media and online data as a part of a broader ecosystem. We looked at other alternative real-time sources of data as well from the public health space, and we built a two-phase machine learning pipeline that would combine many disparate data sources, complementary data streams of real-time information together to identify rates of suicide throughout the country. So what were some of these data sources, right? So we looked at health services administrative data, so visits to the emergency rooms throughout the country because of a suicide or self-harm related reason. We looked at meteorological data. We looked at macroeconomic data, whether it's housing data or unemployment data. And then we looked at online data, where we looked at Twitter, Reddit, Google Trends, and YouTube trend data. And then what we hypothesized is that when we combine signals from these varied sources, it would enhance the accuracy of our estimates that we could potentially have with only one data source. And also there are the problems of single data source, as we have seen from the Google Flu Trends effort several years back. combining different data sources gives us an opportunity to not just counter biases that might exist in any one data source, but also play on the strengths of each of these data sources and overcome the weaknesses that may have. So I'm not going to spend too much time on our architecture, but like I said, we had a two-phase pipeline. We trained individual forecasting models for each of these data sources, and then we combined them using a deep neural network to obtain weekly estimates of suicide fatalities throughout the country. So what did we find, right? We found that these different individual data sources, some of them did well, some of them didn't do well, but there were essentially two ways you could think about these different data sources, some of which were good at predicting the trend, and others which were good at estimating the absolute values of suicide fatalities. But what happens when you combine them? Because that is sort of the point that we are making here, is that when you combine data sources, you do better than any of the individual ones. The row that I would like to draw your attention to is the very last row in this table. When you combine all these data sources together, we find that we do really well in terms of annual estimated rate of suicide, which is within just a 0.5% error rate of the ground truth, which in this case is the number of suicide-related deaths in the US population in 2017 per 100,000 of the population. But even if you kind of go look upwards, you would notice that when we combine different data sources, we do well. For instance, when we combine historical suicide fatalities data with health services data, we do very well in predicting the trend of the suicide, which is given by the high Pearson correlation coefficient. But then if you look at online data sources, when they're combined together, which is Google, YouTube Trends, Reddit, Twitter, and Tumblr, we don't do so well in terms of trends. But if you look at the SMAPE or MAPE estimates, they are very low, meaning that they're good at predicting the estimates. So when you take it all together, it tells us that the major takeaway is that combining these data sources can give us a lot of value in giving us a real-time estimate of suicide that potentially overcomes the challenges of not just traditional ways of public health outcome estimation, but also hopefully overcome some of the challenges that individual data sources might experience. Because the person who is likely to post on social media about suicide is probably not the person who would show up in an ER, in an emergency department. And the person who picks up the phone to call the National Suicide Prevention Hotline is probably not the person who is going to search about suicide on Google. So when we bring all of that together, we are able to get a much fuller and richer picture that pays attention to different sociodemographic groups who might be impacted by suicide. So, this was, we are very excited about what we achieved in this work. Currently, CDC is considering making these algorithms a part of their suicide surveillance system. There are many questions, lingering questions that would come up going forward, like how frequently do we retrain these models? How do we deal with the case that, the landscape of social media and online platforms are changing. So what is the dominant platform today may not be tomorrow. So how do we deal with those research challenges going forward while it is also being practically used? And then finally, this third case study is a collaboration with yet another different stakeholder. And I'm going to keep this one a little bit brief. So this is a collaboration with a nonprofit organization called Everytown for Gun Safety. And they advocate gun sense laws so that societies and communities remain safe from the harmful impacts of firearm fatalities and firearm incidents. So a year and a half back, folks from Everytown reached out to me with a very alarming anecdotal observation, which is that a lot of K through 12 schools in the US are conducting these drills as a crisis preparedness measure against mass shooting incidents in schools, but they have heard from their grassroots partners that these drills are actually having a really negative impact on the mental health of the kids, the teachers, and the parents. So the point here was to understand if there is evidence behind these observations, behind these anecdotal reports, and can we understand what kind of psychological impact are these active shooter drills having on K through 12 school communities? Because if these are not efficacious ways to prepare these communities against gun violence incidents, then maybe we need to rethink the whole paradigm of how do we make schools safer so that they can be places where safe spaces where children can grow and learn. So in this work, we adopted a three-prong methodology, again, with an action research lens to it. So we had a survey where we collected, till date, the largest data set of active shooter drills incidents that were conducted in 33 states in the US, spanning 114 K through 12 schools over one academic school year. We paired it with social media data that was collected from Reddit and Twitter, over 50 million social media postings over a 6-month period total around these drill incidents. And then we followed these up with focus group interviews with 34 stakeholders. So what we found is that over a period of 90 days following these drill incidents, irrespective of which school district, what drill tactic, and the time of the year, we noticed a significant increase in stress and anxiety and depression in these communities. That increased by about 39 to 42% in this period, and not just increased, but actually these trends sustained over time. What we also saw here is basically that people's experiences in the aftermath of these active shooter drills were not very positive. People felt overwhelmed. A lot of kids, a lot of teachers felt that these drills were, in fact, just like the actual shooting incidents, which defeats the whole purpose of this kind of a crisis preparedness model, because the whole point is to reduce the trauma of these incidents. But what we find is that the drills themselves are probably ending up traumatizing these stakeholders. So you might be wondering, to what extent can we attribute these changes to these drill incidents? So to answer that question, we adopted an observational causal inference approach. So we looked at other time periods for these school communities at a different point in time where there wasn't an active shooter drill incident or another local incident that could likely exacerbate their mental health. And what we found is that the changes that we see for stress, anxiety, and depression in the aftermath of the actual incidents is nowhere present in these other baseline control time periods. So altogether, these what this research told us is that there are unseen costs to these training strategies, and by working with Everytown and adopting this active action research lens, it allowed us to engage with the very stakeholders who are affected by these incidents. So our focus groups provided us insights to explain the context behind these sharp increases that we saw for stress, anxiety, and depression. So it allows us to understand why are these things increasing and how, not just to what extent. It tells us that it makes us question if any of these drill tactics are evidence-based at all. I mean, we know that they are not developmentally informed, but what this research tells us is that they are actually having deep negative impacts on the psychological health of these communities. So, the main takeaway here for an organization like Everytown who wants to advocate for gun sense laws is that there is a trade-off that has to be navigated when we think about preparing these K through 12 communities against gun violence incidents, and then also thinking at the same time about the psychological ramifications of these very preparedness programs. All right, so I would like to start closing at this point, right? And I would like to leave you with two thoughts. I believe a lot of people in this audience are interested in questions of using AI for societal good. So my two thoughts go this way. So the first thought is that, there couldn't have been a better time to do this kind of work, right? We have so much data. We have finally the computational power that we can now use to target these questions of societal good. But what can we do, especially if we are computer scientists, to not be extractive in our research approach, right? So the main thing that we have to recognize is it's not just social problems that we are trying to solve with a technical approach, which it is, if you look at the nuts and bolts. But when we are doing that, we cannot lose sight of the fact that we are actually tackling a socio-technical problem, where the social and the technical are deeply intertwined, and we cannot look at one without the other. The second thought I wanted to leave you with is the importance of responsibility and accountability in the research process. So a lot of the problems, like the ones I discussed, and maybe a lot of the ones that you all are working on around AI, at the intersection of AI and social good, these are not just inconsequential problems, right? These are not Kepler's laws of planetary motion. These are real problems that impact real people. And they are not just an academic endeavor that we write a series of papers on, but actually these can have very deep impacts on people and society. So how can we be not just good researchers who do high quality work, but as Mahatma Gandhi had said, how can we ourselves be the very change agents? Because that is also at the crux of the action research framework. Like, how does your research now bring about transformative change? And I think that has to be very much a part of research around AI and societal good. I told you about these three stories, three case studies about how, as computational and computer scientists, we can engage deeply with social science insights and approaches. And this is just one way to think about it. But I think the bigger takeaway here is how can we use participatory, collaborative, and these multi-stakeholder faceted research approaches that can become more mainstream and important and recognized. And this is very important because we want to do our research. When we do our research, we want to pay attention to how do we build trust in communities, right? Because eventually we want these research to be useful in the real world. And with diminishing trust in technology, this is an important point that we have to pay attention to. How do we support graceful failures, right? Because we have to acknowledge these algorithms are not going to be perfect and well-functioning all the time. So what can we do? How can we prepare for the worst scenario when our algorithms or models don't stand up to a potential use case? Or importantly, what I really believe in is how can we adopt the Hippocratic oath that physicians take around doing no harm and make that central to doing good AI and social good research? The question really is, what is a path forward that we can, think about while doing this kind of work that are just not just afterthoughts. They are not just part of the discussion, in a panel or in a paper, but rather how do we make these things very much a part of a new paradigm altogether? As my favorite writer, Thomas Kuhn, said about paradigm shifts. So what is that paradigm shift when it comes to AI for social good? So with that, I would like to thank you for listening, and I would like to acknowledge and thank all my students, collaborators, and funders, without who none of this work would have been possible. And I think I have a few minutes to take some questions. Thank you very much.
Thank you, Moonmoon. That was a very interesting talk. We have a couple of questions. The first one is from Nicole Lin. Nicole, do you want to unmute?
Sure. Thank you so much. Thank you so much for the interesting talk. As just throughout your talk, I've been just wondering about how can we explain the models that we use to find mental health problems. I'd be curious to hear you elaborate more on if you have looked into the interpretability of the models they use and what signals that they're actually picking up in the social media. Thank you.
Yeah, I have a lot of thoughts, first of all, about interpretability, and I could spend another hour, but I'll try to keep it brief. So broadly speaking, interpretability has its place. Not everything in the world today is interpretable, right? So when a physician prescribes you medication, the physician doesn't necessarily understand all the chemical properties and reactions of how the medication is going to impact the biology of the individual. But they have a working understanding of what the medication can do, when to prescribe what medication for what purpose. I think that is true here as well. And there is no one size fits all use of AI that you would put everywhere and where everywhere you would need interpretability. We have to tailor the question of interpretability, transparency, explainability, all of this tailored to the specific context where it's being used. Sometimes it can take one shape and form, other times it can take another shape or form. But we cannot lose sight of the fact that it can mean different things in different contexts. So to give you an example, in the work with CDC, this did come up because we did build a deep learning model. But they were not worried about interpretability in that case because they wanted to get the best possible estimates possible, because in their risk calculus, the risk of a poor prediction, poor estimate was much higher than not being able to understand what is going on inside the black box. So yes, interpretability is super important, but it also depends upon who is going to use it for what purpose and what is their risk calculus in how they want it deployed.
Thank you.
Arman, you're on mute.
You were on mute.
Oh, sorry. Nicole, do you want to introduce yourself? Like, what's your affiliation? Who are you working with? Quickly before we move to the next question.
Sure. I'm a little bit embarrassed about this because I'm not currently at Harvard. I'm a research fellow. I'm currently a research fellow at Stanford's Regulation, Evaluation, and Governance Lab. I primarily work on machine learning for environmental protection currently, but I am hoping to join Milin's lab this coming year, and then we're gonna have a conversation later this week. So happy to meet everyone.
Cool.
Nice to meet you.
Nice to meet you. The next question is from Daniel Alabi. Do you want to introduce yourself and ask your question?
Oh, hi. Can you hear me?
Yes.
Yeah.
All right. Yeah. So I'm Daniel Alabi. I'm a PhD student here at Harvard, working with Salil Vadan. But yeah, thanks for the talk. And so my question isn't really related to like my research area, but yeah, I was just like wondering, I think you were going through the slides and you were talking about the way the CDC uses the data for they do some analysis, but then it takes about a few years, like 2 years to get the data. And I'm just wondering why it takes that long, and if it's possible, I mean, I don't know, based on the intuition, based on your field evidence and experience, if it's possible, I mean, for them to use other data sources instead.
Yeah, well, I guess the short answer why it's slow is it's the government and its bureaucracy. But a more, realistic answer is, it's a coordination efforts between many organizations throughout the country, and they work in different speeds. They have different cultures, and it's the typical case of when you want to, put together something big that has multiple people participating. It takes time. And these are death certificates. These are based on death certificates. So by the time, there is a death, the death is examined by the coroner's office, a certificate is written, and then that information is recorded in some sort of database. And then that is also recorded in a national database. It's a time-consuming process. You're right about the second part about using, a different set of data sources, which is exactly the reason why this project happened. They felt that the ER visit data or the calls that are placed on the National Suicide Prevention Hotline, these are valuable public health signals that are currently underutilized. So how can these be paired with something like online data in order to get a more comprehensive picture of what is happening right now instead of what was happening 2 years back?
I see. Thanks.
Cool. The next question is from Neil Gagwad. Do you want to introduce yourself and ask your question? We can hear you.
Can you hear me now?
Yes.
Okay, great. Thanks, Moonmoon, for a great talk. It's an amazing topic. I'm Neil. I'm a PhD student at MIT. I have a follow-up question on usage of social media data. So for instance, like research has shown people's lives on social media are way different than their actual lives. People often don't share what they feel in an honest sense on their social media profiles. So that inherently creates this bias to understand depression or any state of mind that person might be going through. And there are like several historical cases around it. The second thing is social media data represents different age groups. So for instance, senior citizens might not be as active as somebody who's 18 or 17-year-old using these platforms. So how do you think about like false negatives that may emerge from this research to create some sort of policies or tackling treatments for depression, or even like thinking about it from cultural context, which is very heterogeneous. Like depression is very different in the Indian context. The stigma around it is very different as compared to in the Western contexts, where in the US or Europe. So what are your thoughts on the caution that should go with the analysis of these results or interpretation of them when it comes to like actual action making on the ground?
Moonmoon, before you answer that question, I'm going to make a quick announcement that Moonmoon is available until 12:30. So if you want to stay and ask more questions or have discussion, please feel free to stay in the Zoom meeting. Go ahead, sorry.
Oh, no, this was valuable because I would take a couple minutes to answer all those questions. Great questions. So first of all, the truthfulness of social media. So yes, there is research that says that social media is not truthful, but there is also a lot of research that says that in many ways, among the various ways that you can understand people's behaviors, such as through surveys where people lie all the time or they are not truthful, social media is in many ways not any worse than that. So in mental health, that's what that we are dealing with. We are dealing with our gold standard are these self-reports, and patients are known to sometimes not reveal what they're feeling because of impression management, because of stigma, like you said. But many people feel comfortable doing that on a social media platform, such as Reddit, such as Twitter, probably not Instagram. So it varies by the platform. So across our work, you may have noticed that we have adopted different platforms over time, depending upon what the question demands. So the affordances of different platforms are different, which allows people to talk about certain things on some platforms than others. But the way we navigate this issue of truthfulness is we are not just looking at explicitly who said they're depressed. We are looking at lower level linguistic and semantic patterns. We are looking at interactions with people. And these implicit behavioral signals tells us about their underlying psychological state, even if they're never explicitly saying that they're experiencing depression. The next question was about age, and that's a really, really, really good one. Because people, let's say over the age of 65, are probably not on these platforms. But we also have to go back and think about the domain. The domain is mental health. And when do the first symptoms of mental illness set in? That sets in around the age of 16 plus, 16 to 25. That's a very critical age group from, let's say, the clinical perspective, because if interventions can be provided at that point in time, it can have lifelong returns and improving the quality of life of these individuals. So when we are looking at that age group where the onset of mental illness happens, fortunately, we are also looking at data sources where this age group uses these platforms. But that said, I mean, it's not like people, the people at, over the age of, let's say, 65 are not important at all. They're super important. And that's where we have to think about sort of really the limitations of social media and think about a family of different data sources, not just one data source. And you probably saw some glimpses of that in the work with CDC. That was not for the individual level intervention, but you can imagine that there could be, if we are interested in mental health of the elderly, we have to go beyond social media and look at social media as one player among a family and ecosystem of other types of unobtrusive data that we can use to make these inferences. The cultural context was the third one, which is also really good. So if you noticed in the work with Northwell Health, we emphasized on personalized prediction. And I think that is so important because not just every different cultures have different expressions of the illness, but even within a culture, you can have different manifestations of how a mental illness is experienced. So I think we have to go beyond sort of thinking about these modeling approaches that are population level, that look at positives and negatives, and you have like nice and clean pictures of cat and pictures of not cats, and you train models to do that. The real world is much messier than that. The real world is messy because every person is different from every other person. There are confounds of culture, of age, and whatnot. So we have to think about approaches where we acknowledge that our models have to deal with messy data, where even maybe the gold standards are messy as well. Like, what is the true expression of mental illness? We still don't know. We didn't know 100 years back at the time of First World War, where Sigmund Freud started to do his work on psychotherapy. We have done better. Things have improved over the last 100 years, but still our major instrument is self-reports. And that's a big challenge in this case. So we have to move to situations where the modeling is personalized. We are thinking of these models that look at a person's own expressions and finds these aberrations, because that could be one way to deal with these interpersonal differences.